Me. It's wonderful to be here. I've always wanted to visit Ann Arbor, and this is my first time here. So it's wonderful to see you all in person. Today, I really push myself to use this talk to get some ideas on paper and out into the world that have kind of been swirling around ever since I started my new position. So I spent a lot of time in engineering school, like in my PhD and master's, doing human-centered design research, and have been kind of moving more and more into the medical world, and now have a faculty position in a medical school. So I've been thinking a lot about what it means to do human-centered design research in this new context, in this medical school context. So I can't promise a lot of answers today, but I do want to raise some questions about what is unique and valuable about human-centered design research. What do we have to offer to medical sciences? And I'm going to start by telling a story. It's a personal story, and I don't usually share a lot of things like this in public, but I think it really drives home a point I want to make about there being a crisis of care in the United States and in the world. So on the right in this slide, there is a screen grab of a paper, an opinion piece that was recently published by Iona Heath and Victor Montori called Responding to the Crisis of Care. And I'm just going to read a section from that paper first. Care happens in the space between people in an unhurried encounter. Only humans in interaction can care. It is in this interaction in which one notices a problem in the other and seeks to respond to the other's predicament to improve their situation. This noticing goes beyond the biological to appreciate the biographical. It goes beyond what makes living possible to consider what makes living meaningful. So these words really speak to me, and these ideas are ideas that I've been pursuing in my research for a long time. And this crisis of care has been really acute in my life recently. My wife and I had a son, our son Arden, in March of 2021. He was born with a rare condition, esophageal atresia. His esophagus was not connected to his stomach, which is a very important connection for a child to have. He was also born 9 weeks early. So we spent a long time in the NICU, and since then it's been a long, challenging road, a lot of positive support from healthcare systems, but a lot of really challenging interactions as well. And this came to a head last November at a time when COVID and RSV were both very prevalent in our community, and Arden got both at the same time. So we ended up in the emergency room. So on the left side of this screen, there are some notes I took, kind of exploring autoethnography a bit, trying to take some field notes while we were there. It's very therapeutic to angrily write field notes in this kind of context. There's also an image of my wife Taylor blowing bubbles while Arden is sitting in the hospital bed. And then there's an image of a screen on the bottom right, a monitor showing blood oxygen levels and heart rate and some other things. That image I took at about 2 in the morning during an especially torturous period. A little more background. So because of Arden's esophageal condition, he's faced a lot of vomiting and airway troubles, which has resulted in oral aversion. So he really doesn't like people around his mouth. He gets most of his nutrition through a feeding tube. And we've worked up until this point, have been working really hard at slowly building towards accepting food and being more comfortable with that. Fast forward to the emergency department, the hospital's protocol for managing RSV and COVID is a lot of suction, sucking out the nose, a lot of trying to place a nasal cannula, which is placing something in the nose to deliver oxygen, trying to place a mask over his nose and mouth. And so for Arden, this was torture. And for the parent, me, it was torture to go through this. And I kept asking myself, does it really have to be this way? Why cannot a health system respond to this kid's particular needs and aversions? Why is there such a crisis of care? So I share that story to really drive home that we can deliver healthcare better. So who am I as a researcher and what am I working on? I'm a design researcher creating digital tools to make healthcare more person-centered for people with complex health needs. My research is driven by commitments to identifying and pursuing meaningful health outcomes, so not just outcomes that are important based on medical science, but outcomes that patients care about. I'm committed to honoring people's lived experience and expertise and pursuing health equity, justice, and liberation through my work. The methods I use are often qualitative and interpretive, a lot of iterative design, participatory design, and increasingly community-based partnerships, although this take time to build in a new context. I want to start with an interactive activity, actually, and not just talk at you this whole time. A lot of my work involves understanding what's important to people and trying to reorient healthcare around that. So shown on the screen here is a set of questions, and the main question is, what is most important to your well-being and health? I encourage you all to spend a minute thinking about this, and if you have a computer or a pen, write down some answers. I'll take about 2 or 3 minutes just to give you a chance to look through this. So start thinking about that now. I'm also going to read the domains just in case. Yeah. So the activities of things that are important to you might be activities. So pursuits are things you do. Possessions, things that belong to you. Emotions, feelings or moods you experience. Relationships, connections with other people or groups. Principles, belief standards or virtues you live by, and abilities like physical or mental capacities or skills. So what's most important to your well-being and health? All right, 1 more minute to finish jotting down some responses. So since this is a hybrid talk, I don't think we can easily pair up and share responses. So I'm going to share some things that I write down when I think about this. And then I'll ask if anybody else wants to share as well. So on the screen now are 2 images. On the left is me with my son Arden in a backpack, and I'm on cross-country skis. And on the right is my wife and son and I with some friends in Arizona, wearing hiking boots and shorts, as well as hiking backpacks carrying their son and my son. So it's really important to me to be active outdoors. I get so much out of it. It's really important to me to spend time with my family. So these photographs capture, you know, how important, especially these 2 are to me, Arden and Taylor. These things matter a lot to me when I'm engaging with the healthcare system and when I'm not, when I'm engaging in my work and when I'm not. And it's not easy to separate these things that are important to me from other aspects of my life. Is there anybody else who would be willing to share something that's important to you, something you wrote down? Yeah, Olivia.
An activity that's really important to me is going to Orange Theory Fitness, the gym. I love that. My favorite part of the day, running for sure, and walking in the park.
So going to gym class and walking your dogs. Both really important activities. Anybody else? What's important to you? Robin? Mm-hmm. Nice. The feeling of accomplishment, having accomplished something, and the rest that comes after. Absolutely. I feel like, don't know how to find the chat on here, but if you're on Zoom and you want to share in the chat for posterity, we're recording it, feel free to share. Yeah, this activity is a little limited in hybrid format. So these questions and these domains didn't come out of thin air. I'll talk more about where they came from in a second. But my research mission, one of my missions, is making space for this kind of reflection and channeling it into better healthcare. A lot of the research I've done is involving people with multiple chronic health conditions. So living with chronic health conditions in daily life involves a lot of work. So taking medications, exercising, holding down a job, coping with changes in your life and an identity due to illness, tinkering with treatments, and so on. This work is ongoing. Sometimes it's collaborative, sometimes it's individual. One hallmark of having multiple chronic conditions is facing competing demands. So symptoms and treatment of one condition might conflict or disrupt or interfere with other conditions and with other life demands. So people with MCC often have to prioritize one condition over another, find a personal balance, find compromises that work for them. Ideal care for MCC involves a partnership between the patient and the clinician and others, but especially the patient and the primary care clinician, to target problems, to plan care to address those problems, and to follow up over time as the patient's conditions change and life changes. That partnership, collaborative care partnership, is really important. But that relationship often breaks down for people with multiple chronic conditions, especially when patients and clinicians prioritize differently. When they have discordant priorities, patients have worse health outcomes and worse experiences with their healthcare. So that's one of the core problems that motivates my work, is these discordant priorities are leading to worse care. So how can we help patients and clinicians come to an agreement about what the priorities for care are? And my angle on this is, let's understand what's important to patients. Let's understand their personal values and help clinicians understand patients' personal values so they know where patients are coming from when they articulate their health priorities. So I've done a lot of work in this space over the last few years, and I'm trying not to spend too much time on these past findings. This slide summarizes a lot of them. These findings came from home interviews with patients, aided by photo elicitation, interviews with caregivers at home as well, observations of clinic visits in primary care between patients and clinicians, and then interviews with patients and clinicians before and after those visits. One output of this work is a set of 6 domains that characterize the breadth of what's important to people with multiple chronic conditions. So on the right side of this slide is a grid of 6 Polaroid images, each showing something that a patient in our study took a photograph of to represent what's important to them. So there's a trombone, a pair of golden retrievers, a back porch. So these images come from photo elicitation and home interviews with patients. We analyzed what was important to people through grounded theory methods and developed these 6 domains. And so those are the domains you saw in that worksheet that we worked through: abilities, activities, emotions, possessions, principles, and relationships. And in later work, we found that those domains are actually really useful for eliciting the breadth of values from people. So not just asking, what are your values or what's important to you, but asking, what activities matter to you, what emotions matter to you. We found that that's an effective approach at understanding what people care about. Another main finding from this early work is there are communication boundaries between patients and clinicians about patients' values, about what's important to patients. And these boundaries are mutually reinforced. So on the patient side, patients often filter and withhold what's important to them, especially when they don't see that as pertinent to their healthcare. So like, why does my doctor need to know that I care about my family? You know, I just want them to know that my feet hurt and I would like some pain medicine. So lots of patients sort of perceive that that barrier where when they don't see it as pertinent, they don't want to share it. Clinicians that we talk to actually often did try to understand what's important to patients, like mention specific strategies they use to elicit values. But when they understand patients' values, they're often implementing that understanding towards their own medical priorities. You know, understanding that someone likes to fish helps them motivate that person to manage their diabetes better by saying, like, if you don't manage your diabetes, you're going to lose feeling in your fingers and you won't be able to catch fish anymore. So the problem with that gets back to kind of the motivating problem for all of this research, which is when patients and clinicians have different priorities, there's worse health outcomes. So clinicians understanding values, but pursuing their own priorities doesn't overcome that issue, that discordance. In clinic visits, I also observed a lot of patients and clinicians working hard to overcome these communication boundaries. So we observed some of the types of work it takes, the collaborative work and the coordination to establish the pertinence of values and operationalize them in care planning. So it's not like this is never happening. We have some existing practices to learn from, but by and large, there's a big opportunity to support patients in identifying and articulating their values and how those relate to their health and health priorities. So we built on those interviews and observation findings with some iterative design work. So this new slide shows 6 different images, all involving different design methods of different kinds. And I'll talk through them one by one. So along the top, there's an image of some patients working together at a table, filling out a storyboard as part of a co-design workshop. In the top middle, there is a filled out storyboard. Actually, that's 2 pasted together. The top part is from a group of clinicians. The bottom part is from a group of patients. Those 2 came from co-design workshops we ran with patients, clinicians, and caregivers. We spent a lot of time critiquing current communication about values and imagining how values communication could happen better and what kinds of technologies could enable it. I'm going to kind of skip ahead here. Just want to make sure we have some time at the end. The upper right, we built on those co-design workshops to develop some provocative prototypes and then brought them back to patients and clinicians and focus groups to kind of probe deeper at some of the issues that came out in the co-design workshops. And so one of the main outcomes of that series of workshops was a set of dimensions that characterize the design space for interventions to support better communication about values between patients and clinicians. One outcome of those co-design workshops could have been convergence on a technology or an intervention for us to prototype and implement and evaluate. But we weren't hearing that from people. There was so much range in people's preferences for how they want to talk about values and apply them to clinical care. So we didn't drive forward with design at this point. We kind of pumped the brakes and said, these dimensions characterize some of this variance we're hearing from people. So each of these dimensions, it's not the case that like one end of them is better than the other. They're not normative. They just characterize some variation in people's preferences. So the top one is explicitness. Some patients, some clinicians thought it was important to explicitly ask, what activities are important to you? What relationships are important to you? And then apply those values to care planning. But on the other end of the spectrum, a lot of patients and clinicians thought it was more important to focus on building a relationship. And through that relationship, the values will emerge over time, so more implicitly. So each of these dimensions is important in kind of future exploration of how to support values communication. I'll I'll read the rest of them just quickly. So scale, synchrony, intimacy, guidance, effort, and disclosure. Our Kai paper from 2019 goes into lots more detail about those if you want to know more. So going back one slide to the 6 images from design work, on the bottom row, we, in kind of the next project, wanted to start moving forward with some intervention design. And we were really focusing on kind of more patient-facing interventions to facilitate reflection. So reflection on what's important to them, what they're doing to manage their health, and how those things connect. So on the bottom left, really low fidelity prototype, just involving sets of note cards. The green note cards are values that patients shared with us. The white note cards are self-management work activities. So like being patient with people, maintaining my cool, taking medications. So we just used those note cards in interviews and had people talk through relationships between their values and their self-management work. And that facilitated a lot of reflection just on its own. So we felt like we were onto something. The bottom center image shows a paper prototype that we developed in the next phase of this work. So we took what we learned from the note card interviews, designed 3 different paper prototypes, and then tested them out in a series of kind of prototype evaluation interviews with patients. There's a recent CSCW paper where we report on all of those prototypes, what they do, and what we learned from them. But I'm just going to speed ahead and give you kind of the Cliff Note findings. That work clarified design requirements for supporting collaborative reflection on values and health. So reflection where a patient is working with maybe a health coach or a mental health clinician to think through values together. And then we also that work clarified the role for interactive systems in that collaborative reflection. So helped us better understand what can technology do here, where should it get out of the way, and so on. So one role for interactive systems in supporting this reflection is providing a personalized repository. So a place where you can record what's important to you, maybe update that over time. And that repository acts as a starting point for these conversations to say, you know, these are the things that are important to me. These are the things I've been doing to manage my health. Let's talk through how they relate today, how that applies to what I need in terms of healthcare. And then interactive systems can also be really helpful in terms of providing a shared visual space for mapping out relationships between values and health. There are some inherent limitations to visual space, of course. For example, people who are blind or low vision wouldn't be able to use that. And so there's some work to do to think through externalization in other forms. But I think the core here is externalizing these concepts, getting them out so that they can be reviewed, responded to, really helps deepen reflection on the part of the patient and the facilitator. So check out the CSCW paper if you want to learn more. And talk to me if you want to learn more about paper prototyping, like kind of way too intensely developed applications. We probably should have just built them interactively, like on a computer, but there are some affordances to paper in terms of supporting reflection as well. There's a Kai paper coming out. So back to this image of the six images. On the bottom right is a mock-up of an interactive system that we fully developed. And we've deployed that in a clinical trial and actual clinical practice and try to understand how this actually works for patients and clinicians. So there's a Kai paper this year that y'all should go and see. I won't be there. There's another student leading this work now. So the Kai paper reports on patients' perspectives on this intervention, and then hopefully in the future there will be a paper on clinicians' perspectives as well. So this work continues to march forward. I will come back to this if we have time. This is kind of what I'm doing in this space right now. But in the interest of reflecting on human-centered design and its place in medical science, at this point, I'm asking myself, so we've got this great intervention. it addresses a problem that we've established and documented through a lot of research over many years. We know that eliciting values and reflecting on values is something people enjoy. They get a lot out of it. It can improve their care, we're pretty sure. But how do we actually make a change in clinical practice? And I think the answer to that question looks really different if you're working from an engineering school versus a medical school. So in medical science world, there's many ways to make change, but one primary pathway is you pick a disease or population or outcome. You develop an evidence-based intervention. You implement that intervention. You make a strong business case for it. And voila, practice changes. But the time from generating that intervention and demonstrating its effectiveness and efficacy to actually implementing it is something like 17 years. So, multiple research grants, lots of effort and resources going into that. It can work, but it's slow. So I've been asking myself lately, how is that typical medical science approach limited? How and where does human-centered design fit in this trajectory? And how can I pursue my mission, my research mission, from within medical social sciences? A lot of these ideas are first cracks at this, so treat this as a low fidelity prototype. This is very open to your critiques and your feedback and suggestions. This is definitely not a final set of answers. So how can human-centered design contribute in medical social sciences or medical sciences broadly? I think one important point for us to make is human-centered design is not just a collection of methods. Yes, interviews, focus groups, workshops, those are valuable tools. They help us engage patients, caregivers, clinicians, understand their perspectives, honor those perspectives. Those tools are valuable, but human-centered design is more than just a collection of methods. It's an approach. It follows certain principles. It's iterative, and it's a whole field of research. It's not just a method toolbox. So I think helping medical sciences understand that this is a changing field of research. We're constantly critiquing our own methods, constantly critiquing our own positions as researchers, and moving forward based on that. That's super valuable, and we can contribute that to medical sciences. If we stay small and just apply our methods, I think we miss out on an opportunity there. So the risk, I think, is medical sciences use human-centered design methods without doing human-centered design, which probably will just reinforce some aspects of the status quo that we want to challenge. So on the right, human-centered design's contributions are deeper than methods. If I asked each of you in this room what methods do you use, we'd probably get 10 different answers. There's a lot of plurality in terms of epistemology and methods in our field. And that is a great resource. We constantly have to defend our papers against people who are familiar with other methods. We have to communicate our methods and our approaches across different audiences with different expectations. That's a strength. We practice that a lot, and we can bring that to medical science. We do a lot of framing and reframing of opportunities and problems. So we don't just decide on a problem and then the whole field works on that. We're constantly, doing reflection and action. And acting on the world and seeing what happens and reframing our understanding of problems based on that. We creatively address methods to situations. So we don't just go out and do randomized clinical trials for every problem. We don't apply interviews to every problem. We think through, what do we know here and what do we need to know? And what kinds of engagements can we stage to understand more about what is needed here? We think about that all the time. Creatively addressing methods to problems. We don't just come up with ideas out of thin air. So we have sort of principled imagination of possible futures through engagement with people, through sharing power with actors and stakeholders in the situation. we're radically committed to the idea that people are experts on their own experience. And we're really often willing to highlight in these power structures and challenge them. So we do all of these things all the time in our field as part of, loosely defined human-centered design. And those are all valuable. And we shouldn't lose track of all this like extra work we do just to carry out the methods. So I think there's a big need to articulate these strengths to a medical science audience. And so every day, as a newer faculty member in a medical school, I'm meeting new people, new potential collaborators, and there's such a wide range of expectations about what methods I can offer, what kinds of research I do. I'm constantly trying to articulate what I do, why it matters. And so I think as a field, we can do a better job of articulating these strengths to medical sciences so that we can enter into productive collaborations. So this slide is kind of a very wordy summary of what I'm hoping to do in the near term in terms of practicing some of these ideas and developing them further. So on the left, number one, developing and legitimizing methods. I think there have been some really valuable discussions about what rigor means in design research. So like Daniela, Bill Gaver, and other folks have written like extensively about research through design, like what kind of knowledge is generated through intervening in the world and designing things. It's kind of a different way of generating knowledge than just studying people. So we should keep having those conversations and take the giant and difficult step of trying to convince medical science researchers that these different forms of rigor count and can be useful as well. So there's a couple quotes here from books that I find useful when I'm thinking through these ideas. One is Inventive Methods by Lurie and Wakeford. This quote says, "Our proposal is that the inventiveness of methods is to be found in the relation between two moments, the addressing of a method, an anecdote, a probe, a category, to a specific problem, and the capacity of what emerges in the use of that method to change the problem." So earlier I was talking about addressing methods to problems. I think there's a book-length exploration of what it takes to do that and what we learn through doing that. Not just from applying methods, but continually inventing and reinventing. And then this next quote is from John Law, After Method, Mess in Social Science Research. The quote says, "If we want to think about the messes of reality at all, then we're going to have to teach ourselves to think, to practice, to relate, and to know in new ways." And that is very much understating the wildness of that book and its arguments. But I just wanted to share quotes from both of those because I'm finding them useful as I think through how to develop and legitimize our methods in a medical science context. So in conclusion over there, not employing human-centered design methods in service of clinical science research, but employing them in transdisciplinary partnership. Number two, refining and pursuing principles over profit. I think one thing we do well is reflect critically on what we do and why. So some recent examples are design justice, disability justice, ethics of care is not specific to our field, but germane. And so I think we should continually kind of reflect on the principles that drive our work, because human-centered design is a principled approach. And continue articulating these principles as important in medical science. I'm not saying they don't recognize these as important, but we think about them a lot, so we have something to offer. A quote I included here is from that Heath and Montori paper on the crisis of care. "Responding to the crisis of care through the subversive revolutionary act of building relationships, noticing, and cultivating care." All right, that's not a quote, that's a paraphrase, but just the idea that noticing, just noticing, enabling people to notice, to be more attentive, can be a contribution in the medical field. And then all the way over to the right, number three, critiquing and reworking definitions. I think there's an opportunity, we create openings for new understandings of how to care better when we critique and pick apart definitions that are assumed. So what is the definition of health? You might define it as a state of complete physical, mental, and social well-being. Or we might reconsider that to be more like a dynamic balance of physical, mental, social, and existential well-being in adapting to conditions of life and the environment. So not a state, but a balance. So making these definitional critiques and moves can open up new spaces in design research. Care or caring, this definition comes from Joan Tronto and Bernice Fisher in the Ethics of Care literature. Quote, we suggest that caring be viewed as a species of activity that includes everything we do to maintain, continue, and repair our world so that we can live in it as well as possible. That world includes our bodies, ourselves, and our environment, all of which we seek to interweave in a complex life-sustaining web. So that's an expansive definition that's bigger than healthcare. It brings into view the environment. It brings into view who we are as people, ourselves, and it brings into view our bodies. So I think adopting a broader definition like that, again, opens up possibilities, opens up our imaginations of how to support better care, better healthcare. So I'll stop there. I hope we have some time for discussion and questions. And if we fizzle out, I have more to talk about if we want. But thank you for listening and thank you for having me.
Okay. What the experience has been like defending HCP in the medical context. It's really hard, and I admire your idea, but especially with
Yeah, so the question was, what's my experience of defending human-centered design methods in my new world in medical sciences? Fortunately, it's not that much of, it's not so much defending them at all. I think there is a lot of interest in what we do. There's a lot of need, there's a lot of potential for technologies to make care better, for design research to improve care. And I think funding agencies get that. Study sections reviewing grant proposals get that. So actually, I think there's a lot on our side right now. There's a lot of momentum behind the methods we use. But I think the risk is misunderstanding or having a limited understanding of what we do. And that's kind of more what I'm trying to drive at here, that there's more to human-centered design than making a prototype or like evaluating the usability of an electronic health record change. We do so much more than design technologies and make them beautiful or easy to use. We reimagine what care can be or what living well can be. And we apply that understanding maybe in the design of a technology or an intervention. So I think that's the challenge that I'm facing. It's as a new assistant professor, like in a medical school, soft money situation, I need funding going forward. And so there's some incentive for me just to follow the money, take what opportunities I can. But I'd like to be selective and do work that not only uses human-centered design methods, but like applies the thinking of human-centered design as a field. I think that's where the challenge is finding space to continue thinking about that and articulate its value. Yeah. Thanks for your question. Robin?
prototype and early testing. And it seems like the one prototype, the prototype that, or the system that you're sharing, I tried to get around that and listening values. So can you say a little bit more about how that system works? So part one of the question, and then I think it was commented by maybe someone out there when we were talking about there were some limitations to paper prototyping. So can you say more?
Yes. I'm not sure what they can hear on Zoom, so I'm just going to repeat the questions. So the first question was, how does this conversation canvas system work that the Kai paper is presenting? And then the second question was, go back to those limitations of paper prototyping. So this system in the bottom right, this is like a mock-up, not the actual system, but it looks a lot like this. There's a few main components. So there's this sort of personal library where you can store a patient's values, self-management work activities like taking medications, holding down a job, and like key health outcomes that matter to them, like managing blood sugar or managing pain. So a library of those items.
Is that something that the patient input, or is that?
So a little kind of open. I think the way it's implemented now is we send a patient a questionnaire like the one we did today, and they fill it out on paper, and then they meet a facilitator. So like a health coach. I think that role remains to be designed a little more, but right now it's sort of like a health coach role, someone who knows healthcare to some extent, but isn't a clinician or isn't a primary care clinician. And so the patient's done a little thinking beforehand. They come to that meeting and then they share what's important to them, and that's inputted into the system. I think we imagine the patient being able to edit that directly over time, update it, maintain it, whatever. And then this canvas is another part where you can pull items from that library, put them on the canvas, move them around, connect them. And the patient can do that directly. The facilitator can do that directly. We kind of imagine it being used like side by side facing the same screen or remotely, like over Zoom, but both the patient and the facilitator, health coach person can manipulate what's there. The activity itself follows some steps. So you sort of establish a topic of the conversation. So in this example on the screen, it says, should I give up my home and move in with my daughter in Eastern Washington? So some of our prior research showed that people are especially benefit a lot from this kind of conversation when a big life change is happening. So this is kind of supporting that scenario. They establish this topic, like, should I make this move? And then the facilitator guides the patient through identifying values that are related to that decision, self-management, health outcomes, and then getting those on the screen and then talking through their relationships as they pertain to that question or that topic. So that conversation happens. The information is in the system. We've also been thinking about what kind of output should be sent to a primary care clinician. I haven't been working on that aspect of this project. I think the Kai paper tells you a lot about that, or maybe the forthcoming paper after that. But thinking through, like, what about this kind of, spaghetti diagram would be useful for a clinician? Do they want to see the full image? Do they want a list of insights or questions that the patient arrived at through this conversation? That's an open question of how to translate this network diagram and like the content of the conversation around it into something that a clinician will actually review and use. Question.
Do the patients describe what might be used, what they want to share with the provider? If you recall, and would the healthcare navigator type person, a coach, be able to, would they be writing some style notes that then would the insights that come from that would be generated to share with the patients?
Yeah. So part of the concluding step of the facilitated conversation is the patient declaring some insights that they want to share with the clinician. So that is one clear output that goes from the system to the PCP. And I think they just send it in like a message through my chart or whatever the patient portal is. So, you know, a list of bullets like, you know, I'm considering moving across the state. I'm worried about how that will remove me from my support network here at home, but I'm really excited about being closer to family. I think that will help me manage my medications better because my daughter will help, whatever. So a list of insights from the conversation sent in a message, a text-based message electronically to the clinician. And that's arrived at through the patient and the facilitator talking it through. Did that answer your question? I will say like a lot of this is still kind of open and developing, and I don't think we are declaring that we have the way to do it. But each successive prototype is another attempt at thinking through some of these issues. Yeah. Sorry, can you speak up a little more? I missed like the first part of that. Mhm. Mhm. Yeah, so the question I heard was, have we been hearing anything about changes to identity related to illness or other big life changes, and what are the implications for technology design? So taking a step back from my work, there's a lot of work in medical sociology on illness trajectories, and I think that work by like Corbin and Strauss is where the idea of identity work came from. And I think, or biographical work or identity work. And that concept has been taken up and re-articulated. So that's not something that came from our work. It's bigger and different from our work. Have we heard about that in this work? Absolutely. I'm trying to think of some good examples. When we did the really low fidelity prototyping with note cards, there was a woman who's a bus driver and thinking about retiring, thinking about buying an RV and disappearing across the country. And I remember her saying after the interview, like, wow, I made a decision. I'm gonna quit my job and I'm gonna do this. So I think there's a lot of power in eliciting what's important to people and just creating and holding space for them to talk through what that means for their life and their behaviors. And motivational interviewing is an approach that involves something similar and is kind of well established in like the behavioral health sphere, where you know, maybe want to work toward stopping smoking, kind of have a specific health goal in mind. You elicit the patient's values and then work with them to talk through how maybe they'll stop smoking because of specific values. So there's, again, like it's bigger than what we're doing, but those few examples where big life changes are happening, values elicitation seems really powerful for thinking through. I think one big implication for technology design and like health informatics space generally, I don't know about you, like I haven't been with the same healthcare system for longer than a few years, for a long time now. And so my health information is all over the place, and Epic and some other systems are starting to make it easier to bring that all together. But right now, the status quo is life changes, you move, and your information is somewhere else, and it's a mess. So I think there's a big opportunity for more patient-owned health information. I think that's kind of a whole little field, and I haven't thought that much about longitudinal, like management of values information, for example. I think that's really important to think about because values may be enduring, they may change. What you want from your health may change as your values endure or change. So I think there's a lot to think about there. But my point is healthcare doesn't do a good job of this today. Yeah. Yes.
You mentioned this, I guess that's a great.
Mhm.
But did you ever see that being like a broader analysis? You know, let's finish and saying, oh, our medical system is well, it's kind of weird, but that's important for our life to be. Oh, yeah, and I think the broader question is like, what do we have to do?
Yeah, I love that question. Thank you. Yes, I think I heard like, has the findings or activity of my research channeled towards advocacy at all, or channeled toward broader critiques of like structural conditions, or you know, just the situation we find ourselves in where healthcare doesn't work well, the crisis of care. Yeah, not yet. I think that's an important direction to go. And I think it's something I'm thinking through more as I develop new projects, how to bring some more of that into view. Like getting back to the question of how do we actually make change in healthcare, like working within the healthcare system, you probably need to have a good financial argument. You need a business to make money, right? That's a big constraint. And so maybe we need to work outside of that as well for more collective organizing. But yeah, I haven't gotten there myself yet. And I think it's an important question.
So we'll probably have to end this movie there, but let's thank Andrew.
Thank you so much.
Then you can go to